Standardizing care for heart attack patients. National experience and evidence shows that heart attack deaths can be reduced if patients receive a standardized order of care at the time of the attack. By using those evidence-based standards for care, Emmanuel St. Joseph's has shown that local outcomes can match or exceed the results at larger or nationally recognized medical centers.
This project was chosen for several different reasons. And number one, cardiac causes of death are one of the largest causes of death throughout our country. So a heart attack or an acute myocardial infarction is obviously one of the main killers, and therefore it's important to try to deal with that appropriately. There are some very strict criteria set up by national groups and organizations that also affect how hospitals are reimbursed, but more importantly affect the outcomes, hopefully, of the patient's care.
One of the biggest ones is door to balloon time is what it's called. Basically, the patient presents to the emergency room having an MI. Our goal is to have 90 minutes or less from the time they enter the emergency room to the cath lab where that culprit lesion or the blocked heart vessel is opened. That was what we really focused on, and with that we also look at making sure the appropriate medications such as aspirin and beta blockers are given immediately on admission to the hospital, preferably within the first 24 hours if it's not possible immediately. We also look at left ventricular function, or LV function, which is actually the heart muscle, how much function is there after an MI, to see if there was any damage. There are medications that are also given depending on what that heart function is. They're called ACE inhibitors. That's another one of the criteria that needs to be met upon discharge of a patient. Smoking throughout our community is a huge process right now with going smoke-free and that, and we work with each one of our patients. They are assessed to see if they have had any nicotine within the last year, and if they have, they are given the pat on the back, great job if you have quit, and also are provided resources if they need any help, any assistance in quitting that.
It's all about time.
With all of the core measures, of course you worry about quality of life. You also worry about, are those people still alive? Nationally, we've worked very hard as a medical community to try and decrease the mortality. That has worked. One of the reasons we focused on the door to balloon time was exactly that. That one we know helps people live. And so we spent more time on that than other parts of the project because of that. And it has indeed certainly decreased the mortality that we've seen here as well.
Prior to us putting the committee together and this really, the national awareness of this door to balloon time, we had a couple cardiologists, interventionalists that were very in tuned to these. Dr. Houlihan is one that, prior to all of this, he's our research man, and he was trying to get all of this implemented kind of behind scenes. Working in the cath lab, I just remember one of our physicians, Dr. Ravindran, an acute came in and he looked up at the clock, and it was 6 minutes after we had started the case. So the patient was on the table, and I distinctly remember him looking up at the clock, and I asked him, I said, "What are you looking at?" And he's like, "Lesion's open, 6 minutes." So our physicians are very aware of it. The emergency room has been one of the areas that has really made this happen. They have trained their technicians to have EKGs done within less than 5 minutes, where prior to this happening, it was probably averaging around 15 to 20 minutes before an EKG was done once the patient presents with chest pain symptoms or MI-type symptoms.
From a primary care provider standpoint and from the emergency room standpoint, it has very much empowered us to be able to call and talk to the cardiologist and not feel bad about that. They're busy people. We respect their opinions greatly and we respect their time greatly. We don't want to bother them, but we also realize that, hey, when one of these comes in, everything else has to stop. That's what you're dealing with, and that's what you have to act on right away. And it has really broken down a lot of barriers to get these patients, these people, taken care of.
It's all about value.
We are a system here that, Emmanuel St. Joe's Mayo Health System, that we can provide care just as, say, Rochester or Abbott. We have the resources here in the community so that they do not have to travel the distance. They don't have to be away from their family as they are getting through this process.
One patient's story.
Well, it was about between 12 and 1 o'clock. I woke up and with severe shoulder pains and pains in my arm. And no matter how I laid in bed, I was very uncomfortable. About close to 5 o'clock that morning, I woke up again with the same symptoms, but a little worse. And at that time, I got my wife Dee up and told her I think we have to go to the hospital. And so she drove me to the emergency ward in Waseca. And they give me, as soon as I got there, they put me in a wheelchair. They give me nitroglycerin and
baby
that
aspirin.
couple times, I think, at least. And and after that, they asked me if I wanted to go to Rochester or Mankato, and I said Mankato, so they said they'd give me a helicopter ride.
I'm not positive, but it must have been somewhere around 7:30, 20 to 8.
And when I got into Mankato, they rushed me right down and right in, and by 8 o'clock I was back in my room. Everything was all over with already, and I felt very good.
I think Dr. Houlihan did do a good job of explaining to us what was to be and what to expect. And when we went back for our checkup in August, I asked the doctor then what damage had been done. He told me, he showed us a picture of the heart to what damage.
A lot of times I get kind of awful tired, you know, or get like I used to walk up from the boat lift up to our camper, and sometimes I'd get pains in my arm a little bit. And when I was doing that, and it seemed like now I don't have that anymore.
I see this from the singular patient that's being dealt with. I think that it makes a huge difference potentially to their quality of life, not just their length of life, but their quality of life, whether they will have the ability to walk further, whether they'll have the ability to do some of their hobbies such as fishing. It makes a big difference in what they're able to do. Kim has said numerous times throughout our meetings that time is really heart muscle, and the more heart muscle you have, the faster you get that blood supply back to the heart, back to those muscle fibers, the more heart you have to work with. And that can make a huge difference to their quality of life, just to that one patient. You start backing away from that a little bit, and then you start to see society's benefits. These people can stay employed, they can keep doing things, they can keep doing what they enjoy doing. And that makes a huge difference, not just for that particular patient, even though that's very important, but just from our societies and our communities aspect, that makes a huge difference